you wear your genes every day, so you need to learn what they're made of. Some things are pretty obvious, the things we inherit from our parents, like the brown hair that my children all got from me, and the brown eyes they all got from their dad. Nobody got green eyes from me. But we're going to go a little bit deeper today and talk about some of the genes that can be related to breast cancer risk. Throughout my presentation, you will shamelessly see probably all of my family members. I can say that this is the first time in the 13 years that I've been at Piedmont I've never had to do a no disclosure slide. I felt like it was necessary tonight because I am going to specifically show you pictures and mention some of the laboratories that we use. This is Finley, our Weimaraner, and I chose these pictures because I think sometimes we choose a specific lab because we think it's the right one, and don't think that there's any difference and are excited about getting started with genetic testing, hence the puppy. And then at the end of the process can have some frustration and complications, whether it has to do with insurance or not getting the right genes tested or other, complications that could come in. But I have no affiliations with any of the labs that you would see mentioned here. So what's new in breast cancer genetics? I thought I would just dispel one of the most common myths that I see when patients come to see me is that I'm not really testing you to see if you have these cancer genes. I know you do. I know you have BRCA1 and BRCA2 and all of the other cancer genes that we're going to talk about today, and a lot that we're not. But we're all born with these genes. Their normal job in our bodies is to help prevent cells from turning into tumors. So what I'm really testing you for is to see if they're functioning correctly. I want to know if these genes are doing their job. Are they working the way they should be? So this is a little bit of the evolution of breast cancer genetics. In 1994, 24 years ago, they found breast cancer gene 1. They named it BRCA1, which is lovely of them to name it and abbreviated, but BRCA1 and BRCA2 as they're most commonly known. Commercial testing started about in 96, and then we just did BRCA1 and 2 for years and years. That's all we did for breast cancer patients, unless somebody had a family history of more rare cancer or a different cancer that sparked, maybe one of the more rare cancer genes that we could look at. And that's a lot of insurance. That's what they paid for, was BRCA1 and 2 testing. The technology with which the lab that did this testing improved a little bit in 2007, bumped the sensitivity of us being able to find mutations in BRCA1 and 2. And then 10 years ago, Gena passed. And I can tell you that the first few years of my work in cancer genetics, the top two questions I got was, how much is this testing? And what about my insurance? Am I going to lose my insurance? Am I going to be discriminated against? So when Gena was passed, basically that came along and said, it made it illegal for, can you hear me okay? I feel like, made it illegal for health insurance companies to limit or deny coverage on the basis of a genetic test result. So that got to be a less popular question. In 2012, panel testing started. Panel testing has revolutionized the way we do cancer genetic testing and a lot of other areas, cardiology and other areas as well. And what we do by panel testing is say, well, we're really curious about BRCA1 and 2. They're always the first two genes we want to cross off the list when we're worried about hereditary breast cancer. But let's look at some more. Let's look at some more of these rare genes that maybe we just don't know as much about. And then the big fallout happened in 2013. Angelina Jolie tested positive for BRCA1. It brought a lot of great public awareness to this genetic testing. She spoke very openly about some of the decisions that she made and regarding her medical management. But what it did, again, brought that public awareness and the platform for the one lab that had a patent on the process for testing these two genes was finally brought up to the Supreme Court, and they said, you know what, no more. We're going to take away that patent, and we're going to have a little bit of a competitive marketplace. So that has essentially all of these other genetic testing labs were able to add BRCA1 and 2 to their panels, which insurance companies already knew about. They were happy to reimburse. So we started to get all of these genes looked at. Now, in 2018, it's not uncommon for us to order an 83 gene cancer panel on patients. They are not all breast cancer genes, but that's kind of one of the largest panels that we offer. So the topics that we're going to specifically discuss tonight are when individuals with breast cancer should consider testing, And who else needs cancer testing? Because obviously you don't have to have had breast cancer to be a good candidate if you have strong family history. And then the commonly asked questions, the logistics, right? The nuts and bolts. How do I get this done? How does it work? What labs do I choose? Tell me a little bit more about insurance versus self-pay. And then genetic discrimination. I'm going to touch a little bit more on Gena at the end, and then just briefly mention DNA banking. So who should consider genetic testing? Pretty much this list encompasses the black and white, it's not all encompassing, but sort of black and white obvious indications with the exception of one in the middle that I'm going to talk about a little bit more. If you've been diagnosed with breast cancer under the age of 45, that's the red flag, your young age at diagnosis. Unfortunately, as we age, we expect to see cancer happening. Our cells get older, the likelihood that cancer occurs goes up. But when we see cancer happening at a young age, cancers that shouldn't be happening at a young age, it begs the question why. Could you have been born with a predisposition to develop this cancer? And that's the red flag, regardless of family history. Male breast cancer is rare. So anytime we have male breast cancer, it's an indication to look at BRCA1 and specifically BRCA2. Breast cancer at any age and Ashkenazi Jewish ancestry. So we know that certain ethnicities are at risk for all different types of genetic diseases. If you're of Ashkenazi Jewish ancestry, Northern European Jewish ancestry specifically, your carrier rate to have one of the BRCA1 or 2 founder mutations is 1 in 40. And that's without a diagnosis of breast cancer, right? So if you have breast cancer at any age, or a strong family history, or any family history, it's worth talking to your doctor about getting genetic testing so that we can take a look at that. And this is the one that has some caveats. Breast cancer at any age and concerning family history of cancer. Concerning is the key word. What's concerning to national guidelines, what's concerning to your insurance company may not be what's concerning to you. But we encourage all people to just ask the questions. Guidelines are changing fast, quickly. We're constantly getting new indications for genetic testing. So we never mind answering questions about, how much family history is enough, how much of different cancers come into play, those kinds of things. Ovarian cancer is an automatic indication. 25% of all ovarian cancers can be linked to a hereditary gene. Before panel testing, that number was 10%. But since we're starting to look at more genes and get all of this data, it's been bumped up. Metastatic prostate cancer and metastatic breast cancer as well is an indication for testing. It's an indication because it could have implications for treatment, what your medical oncologist might recommend for you for treatment. All pancreatic cancer, this just came out just within the last couple of months. We should be doing genetic testing for all of these folks. And anyone who had testing before 2013. Because I can guarantee you just had BRCA1 and 2 looked at, or maybe another gene, maybe 3 genes. But if you had testing before 2013, you got to come back in for update testing. Genetic testing is not a one and done. It's sort of let's keep investigating, let's keep looking until, or if you ever test positive for something that can explain the history that you've had or the family history that we're concerned about. So is breast cancer hereditary? Well, the green part of the pie here, the sporadic, 12% is the general population risk for breast cancer. The word hereditary basically means, is there something in your family that's being passed from one generation to the next that's putting you at higher risk than general population? And the things you need to look out for are on this list. And it's important to kind of know what we consider or worry about with hereditary cancer, because not everybody with hereditary cancer, not everybody in that pink wedge, that 5 to 10% is going to test positive for a gene. But it doesn't mean we wouldn't manage you accordingly. It doesn't mean we wouldn't manage you as higher risk. So some of the signs of hereditary cancer can be young age at diagnosis, multiple cancers in a family, multiple family members with related cancers. Well, if you don't know what cancers we consider related, we mean related through genes. Like BRCA1 and 2 we know are linked not just to high risk of breast cancer, but ovarian cancer as well, prostate cancer, pancreatic. So we worry about certain clusters of cancers in a family. And then rare cancers can be an indication as well. So when you break out that piece of the pie and you see BRCA1 and 2, they're what I like to call the most common of the rare. BRCA1 and 2, the incidence of these genes in the general population is about 0.2 to 0.4%, right? It's a pretty low risk that just anybody out there has a BRCA mutation. But When we specify and we look a little bit closer at our breast cancer patients that are testing positive, half or a little more are because of BRCA1 or 2 mutations. And then you see here we've got newer genes, we've got what we call moderate risk genes, other high risk genes, and then that sort of light wedge in the back there are the undiscovered genes. And again, it's important, I saw a patient today who was 37 with breast cancer, and her paternal grandmother had breast cancer at 37. She's tested negative for everything we looked at recently and in 2004, right? That doesn't mean there's not something hereditary going on there. It just means we may not have the technology to find it. She, her daughter, her sisters, they all need to be managed at high risk. So these, well, I named it newer breast cancer genes, but I have to be honest, the high risk genes here, these are not new genes. We've known about these genes for a long time. I don't know if you can read it, but BRCA1, breast cancer gene 1, breast cancer gene 2, because we found that one second. And then genes like CDH1, P10, STK11, they're not named as nicely when you start going through the list. I mean, it makes it a little bit harder to figure out which types of cancers are related to those gene risks, but we've known about them for a long time. We just didn't test patients for CDH1 if there was no family history of gastric cancer. So if there was no family history of stomach cancer, that gene is so rare, we didn't look at it. But with panel testing, we started to. We name them high-risk genes, and you can see kind of their lifetime risk, 45 to 87%. When you get into the moderate risk genes, that's what they're calling 20 to 50%. Still higher than what we would want to see. So we have medical management guidelines that have to do with how we screen these individuals. CHEK2 may be one of the more common moderate risk genes that we see. This is a breast cancer gene that can also lead to slightly increased risk of colon cancer. The BRCA genes don't cause increased risk of colon cancer, but CHEK2 does. So again, it really depends on what gene someone tests positive for as to how we manage them. And then in the far corner, we've got lots of new and sort of moderate risk genes. Some of them we've got guidelines for, and a lot that we don't. So we may say, well, that we know this is a breast cancer gene, but we don't know what the lifetime risk is. We haven't studied it long enough. And we're hoping that as time goes on, we've just been doing panels for 5 years, but as time goes on, we'll get more and more information and be able to better understand that. So how does it work? Blood or saliva. So not a swab, but actually spitting into a tube, about that much saliva, is how we get the DNA for the testing. And it doesn't matter if we get it from your cheek cells or if we get it from blood, the DNA is the same. The only difference when I'm asked the question, which one's better, which one's more accurate, which is quantity. Sometimes we just can't get enough DNA from those cheek cells for the lab to run the test. So if it's a situation where you've got someone who's surgery pending or someone who lives an hour away or it's really hard to come back in, blood is a good option because then it really reduces the likelihood of a saliva failure. But both are still really good. Saliva failures happen just maybe a couple times a year, so not often enough that we don't offer it. The level of testing and the number of genes you want to look at depends on the lab. Sometimes labs have preset numbers of genes that you can look at. Other labs, it's more of a la carte. You can kind of pick and choose. And then most of the labs do a billing check for you. Results take about 2 to 3 weeks to come in, and the testing is really kind of only contraindicated in a few situations. Some hematologic malignancies we have to get clearance for, and that has to do with the technology, the way they're looking at the genes. If you've had a bone marrow transplant, if you've had a blood transfusion within the last couple of weeks, we don't want to draw your blood and end up reporting out someone else's DNA test results. So there are only a couple of things that we have to be careful of when we're talking about who's a good candidate for this testing. So ways to get tested. This is lovely Amanda Epelita. She's one of my colleagues. This is the traditional genetic counseling format. Your doctor's involved with this. They're going to refer you for genetic counseling. You're going to come in. We're going to review family history. One of the most important things we do is your risk assessment. It's not necessarily going up through 83 genes and going, well, I'm not really sure if I want to know about the retinoblastoma gene, which causes a rare eye cancer. No, it's about saying, well, let's look at the family history and go, okay, well, with the amount of breast cancer or colon cancer in the family, should you be doing something more? So this process kind of keeps your doctors and everyone in the loop. So these are some of the labs I talked about. There are a lot more labs that do genetic testing these days. The 4 here are the ones that we use a lot. The genetic testing labs, it's not the technology. We're doing next-gen sequencing. Looking at these genes is what it's called. The labs can all do next-gen sequencing. That's not where the value is. The value is how do they interpret those results? And that's what we want to know. We want to know that these labs have the genetic counselors, the medical, the PhDs, the people on the back end who are able to look at that and go, well, do we really think this is inconclusive, or do we think this is pathogenic? Do we think this is linked to cancer risk? They vary greatly, and we choose different labs based off of what insurance you have. We choose different labs based off of what kind of cancers are in your family. Do you have a lot of colon cancer in your family? Well, we may choose one lab over another because they're looking at more colon cancer genes. And then the sort of the kid on the left is the one we use a good bit for DNA banking. Now this is what's another revolutionary thing with genetic testing, right? It's direct to consumer. So they've been doing direct to consumer marketing for a while. There were Myriad's breast cancer commercials years and years ago. So that's nothing new. But what is new is that patients, people, anyone can order genetic testing from home. They'll get a saliva kit. This is clinical grade genetic testing, right? A 30 gene panel like what we would order for you. Your physician does not have to be involved, and you get results in a couple of 2-3 weeks, right? So a very similar process to what we would do. But the limitations are your doctors aren't in the loop unless you bring those results to them. And I can't tell you how important it is to make sure that you get those results into us, into your doctors. How many times we've had patients come in and go, oh, my sister's positive. Positive for what? I don't know. BRCA1, BRIP1, not sure. So knowing exactly where that mutation is really important. Direct-to-consumer testing, you're not really getting that family risk assessment. You're not getting that big picture look at what you should be doing if everything is normal. And I can tell you that most people we test, the vast majority, they're negative. Most cancer is not caused because of any of the genes I can test you for. But if it's negative, that doesn't mean there still shouldn't be a plan in place. And is it the right test for you? Do you have a family history of kidney cancer? And maybe, again, we should broaden that scope of genes that we're looking at. Should we be looking at more than 30? Color is the name of this lab, and their sales model is different because they're offering what general population cancer genetic testing. It just blows my mind, right? We're so guidelines based. We have guidelines that tell us who we should test and the ages we should test, and all of these things. I showed you some of the guidelines earlier. This lab for $249 is saying, do you want to know? Are you curious? And a lot of people are. We don't know how we're going to meet the demand if ever this comes, to be full scale. But this is kind of this is the future of what's going to happen. So we're all going to have to adjust accordingly. And that's the benefit, I guess, of it is that it's easy to access. It's easy for people who don't live near a genetic counselor who maybe can't, get out to do genetic testing or maybe don't have a doctor that they see regularly to do this. The drawback there is gosh, if you test positive, you really need someone to help you interpret those results and take care of you, tell you what screening you need, and tell you what next steps should be done. So why is it important to know if you're gene positive? If you're a breast cancer patient or a survivor and you have remaining breast tissue, well, we want to know how to take care of you after 5 years, after 10 years. Should we be lifelong high-risk screening? Do we need to offer you other surgical interventions if we find out you're at risk for ovarian cancer, or maybe do more frequent colonoscopies if we find out that you're at risk, higher risk for colon cancer? And again, it could affect treatment options. These days, the genetic testing that we do can impact what sort of chemotherapeutic options your doctors may be discussing with you. And the two reasons people do this testing, the two reasons they come to see me, number one, is because they want to make sure that their doctors are taking care of them, that they have all the information they need to recommend the correct screening and surveillance. And number two is for family. They come in because they want to know for their kids and they want to know for their siblings, who's at risk. So this is my Aunt Sharon, my godmother, who had bilateral breast cancer at 75. And she had BRCA1 and 2 testing, but not update testing. So even in my own family, we're still pushing the envelope a little bit, trying to get more for her. But this is 3 generations of my family that benefited from at least knowing she's BRCA negative, and her own daughter for knowing that she's BRCA negative. So predictive testing for females and males, it's not just beneficial for the women in the family to know. Some of these colon cancer, they don't care if you're male or female. The reproductive options, we've had pre-implantation genetic diagnosis for a while. Basically, that's when you can determine through in vitro fertilization which embryos have a mutation and which ones don't, and only implant back in mom the ones that don't. So that's an option. that's been around for a long time. It's not for everyone, either for financial or ethical or spiritual reasons, but it's available. And more we're finding that we need to talk about reproductive options too, because one of the moderate risk genes I mentioned earlier, ATM, so that's a gene that we studied in medical genetics for a long time. It causes ataxia telangiectasia, which is a degenerative neuromuscular disease. And what they found out is that over time, children who had that disease, they were seeing an increased incidence of breast cancer in their moms. So then we thought, ATM is a moderate risk breast cancer gene, but if you have the ATM gene, we need to know, is your spouse at risk for having that mutation? Are you at risk for having a child with ataxia telangiectasia? These are issues we never had to deal with before panel testing, but something that can come up for discussion these days. Again, so why no? This is and I'm sorry it doesn't show up very well, but this is a family that I saw a few weeks ago, or a gentleman that I saw, 32. I named him Gregor Mendel, the father of Mendelian genetics. And so he, in this scenario, is 32 and came to me because his sister tested positive. Positive for what? We didn't know, but she got the results to him while we were in the genetic counseling session, and she tested positive for BRCA1. So sister was 28, wanted to start a family, and I said, gosh, who did BRCA testing? Just, there's carrier testing they do in the prenatal world, but who did that just for her family? She said, no, because my aunt had breast cancer at 40. Well, that makes sense. She tested positive for BRCA. He was coming in to get testing for BRCA, and then he goes, but my aunt didn't have it. I said, really? Are you sure? And he said, yeah, here's the result. And she didn't. The maternal aunt was negative for all of the genes they looked at for that breast cancer risk. And his mom was negative. So this mutation came from Gregor's dad, right? A very male-heavy family history with a paternal aunt that died young. So we don't know what would have happened had she lived, a long life. Would she have been exhibited signs of that? So I think, knowing this information can be critical. It's critical for him. Luckily for him, he tested negative, so we don't have to worry about his girls testing positive. But here's the other thing. His sister, the other one, the 24-year-old sister that tested negative for BRCA1 and 2, she's still at high risk for breast cancer because her aunt had breast cancer at 40. So there, how we interpret some of this information can get really tricky because people go, I'm negative, I don't have that breast cancer risk, but if it's not what is accounting for the breast cancer in the family, then that's not necessarily true. This is my husband, Bill. And he got for Christmas an Ancestry kit from his mother, which I made him do about 3 weeks ago so I could put his picture in this presentation. He was real happy about it. We get questions about 23andMe every other day. That's the new question, right? 23andMe. I had 23andMe. Is that, I was negative for that. I'm good. It's not meant for clinical actionability. The health component of that test, and it's all over their website. And I clicked on everything reading about, how it's meant to be used. We call it recreational genetic testing. We say if you're curious about where you came from, then that's a fun thing to know, right? And these labs, they don't have to be very specific, right? You don't need to know where your great grandmother, what street she grew up on. You just want to know what region she came from, right? So they don't have to be very specific. But we do sometimes get patients come in with raw data from 23andMe, and they'll go, I have 3 BRCA mutations, and we're like, let's do some testing through a CLIA-certified lab, and it's negative. It's normal, again, because these labs are not designed to be used for clinical utility.
So Molly, can I ask a question?
Yes.
Does the 23andMe that checks for the BRCA gene, is that only Ashkenazi?
Yes.
Can you
Thank you for pointing that out. Yes. So, the same patient I saw today who was 37, when I said, what are your sisters doing for screening? She said, they get a mammogram once a year, and my sister was negative for 23andMe. I said, they're not Jewish. It's not a Jewish family. And they're only looking for the 3 founder mutations in BRCA1 and 2. And how I describe this to my patients is, if you think of BRCA1 as a chapter in a book, the way we do this test is we're going to proofread it very carefully, looking for changes or mistakes that are so significant you don't understand the context of the chapter you're reading anymore. So that's a comprehensive screen. But when you're looking at the common Jewish founder mutations, it's very targeted testing. It's like saying, well, on page 4, paragraph 2, sentence 3, that word, that's what we're looking at. So if that's what 23andMe is looking at, 3 locations, that's it. So if you're not Jewish, it's not helpful to have that information. And even if you are Jewish, sometimes it's not the BRCA gene. Sometimes, it can be a non-Jewish mutation that was introduced into the family because someone who wasn't Jewish married into the family. So I still think it's worth evaluation, but yes, it is for only the common Jewish founder mutations. Insurance covers this testing if you meet criteria. Most patients have little to no out-of-pocket, and your genetic counselor, we can tell you billing policies at all the different labs. I can tell you which labs I use to get 0 out of pocket for certain patients that have this insurance and $100 out of pocket for this insurance and no out of pocket if certain scenarios arise. But all the labs check those benefits. They all have financial assistance. We're lucky enough to have grant funds from It's the Journey to be able to help patients out who are in situations that they can't afford the cost of genetic testing. But if patients self-pay, the self-pay rate is $250. And guys, in 2012, just to look at BRCA 1 and 2, it was almost $4,000. So to be able to say to someone, we can help, we can figure out a way to get this information for you, and that's what we do. So this just talks a little bit more specifically about Gena, which is the Genetic Information Non-Discrimination Act. It is for group health insurance. It doesn't apply when we're talking about life insurance, long-term care insurance, or long-term disability. This is specifically for group health. You want to get really specific, they are talking about groups more than 15, and it doesn't really apply to people in the military. So Gena's been around for a while, but I have started getting questions again about whether or not people need to be concerned about insurance, but the laws are still there. This and the state of Georgia has a genetic non-discrimination law as well. So how can you keep up to date on genetic testing as advances are made? You can check in with me, email, give me a call, or any of my colleagues. We have organizations like FORCE that, may be thought of as support group organizations, but boy, they're really powerful venues for getting out information. And oftentimes, I remember looking through a FORCE newsletter. This is Facing Our Risk Empowered. It's specifically for patients with genetic mutations and breast cancer risk. And I remember reading the newsletter and I go, gosh, I didn't know that ovarian cancer screening trial was even going on. So they're good resources. And then DNA banking, for $170, somebody could bank their DNA. There are situations where this is helpful and important to know that we can do that, and they'll hold the DNA for maybe 50 years at least. Again, just some more resources that we have. FORCE, Bright Pink, Genome, NSGC, which is our National Society of Genetic Counselors, and then any of the genetic counselors at Piedmont or in Atlanta. We know a lot of them. They're great. This is our team, so we're lucky there's 4 of us now. Me, Amanda, Kelly is in Fayetteville and Noonan, and then Dylan just joined us this spring. He's fabulous, working in Atlanta, and then in Piedmont Henry in Stockbridge. So we're grateful to be able to have those resources and doing some telegenetics as well in some of these locations.